Let's all stare.
I'd whistle if
Good
I
evening and welcome. I'm Chuck Hewitt. I'm the Executive Vice President here at the Jackson Laboratory. And on behalf of the lab, I want to welcome all of you to what is a first for us. We're pleased to have you with us tonight to discuss addiction, which, as you know, is a serious problem in Hancock County, in the state of Maine, and nationally. In fact, I was shocked the other day to learn that here in Maine, we're now averaging nearly one overdose a day from addiction. This challenge presents huge issues for our families, for our communities, and that's really why all of us are here tonight. Before we begin, I want to introduce a few people that you should be aware of here. First is Art Blank, the President and CEO of Mount Desert Island Hospital. I know Brian Hubble, our state representative, is here somewhere. Thank you. Welcome, Brian. We have some guests from Maine Medical Center, but I think they're still touring the lab, so I'll pass on that introduction for the moment. But I also wanted you to meet Claire Tully, our Senior Director of Human Resources, and Stephanie Wasco, who's our Senior Director for Communications. And Danielle, I don't know, are you? Danielle's outside, but Danielle Silverman is really the person who did the hard legwork of putting this together along with Stephanie. It's also a pleasure to introduce our panelists tonight. Dr. Dan Johnson, who's the Executive Director of the Acadia Family Center. Alyssa Chesler, who's an Associate Professor here at the Jackson Lab, and Sheriff Scott Kane from Hancock County. And it appears that Barbara Royal is unable to be with us tonight. For those of you who are with us for the first time, the Jackson Laboratory is an independent, nonprofit research institute. We work on a wide variety of diseases, including cancer, Alzheimer's, Parkinson's, obesity and diabetes, and other things. But we also have Alyssa and Vivek Kumar, who do a lot of work on the genetics of addiction, looking at how genetics affect susceptibility to addiction and what the physiological mechanisms are that are triggered in that. I want to emphasize that addiction is not something that happens to bad people. I think Alyssa would be very quick to say that it's not a moral failure. Her work in mice certainly bears that out. Nobody chooses to be an addict, and I expect we'll hear tonight that there are some of us who would never imagine that we could become addicted who somehow have slid into it. And I think that's a very important context. Addiction takes many different forms, but tonight we want to talk about the opioid epidemic and opioid addiction. An epidemic that often involves drugs that are legitimately prescribed, but perhaps also in many cases illicitly obtained, and that involves some very dangerous new drugs that are being imported from different corners of the world that really feed addictions and make them perhaps even worse. Our hope is that with all of us coming together, we can have a constructive dialogue, one that at the very least leads to an increased understanding of the biology, the behaviors of addiction, and what some of our community resources are that we can bring to bear to help solve these problems. I want to introduce our panelists. Well, I guess I did that already, so excuse me, I jumped ahead. So let's move right into to questions. But before we do, Jonathan, I want to ask you, we've had a panelist that hasn't shown up. Would you like to join us?
Sure.
Thank you. We'll have a mic for you in in 1 or 2 seconds, but Jonathan is at the Maine Medical Center Department of Psychiatry, and in that context wears just a huge number of hats, and I'm sure he'll add to the conversation. So while he's getting mic'd up, Dan, maybe we could start with you, and I'd like to ask each of our panelists to share with us one critical insight that you've had in the course of working with people with addiction, kind of an aha moment that you think the audience would benefit from hearing about.
Oh, thank you, Chuck. It's a pleasure to be here. Thank you all for coming. I guess one of the insights I've gained in this work over 30 years is in regard to the opioid epidemic, that we think of opioids as analgesics for physical pain. But I work with a lot of people who have suffered tremendous emotional pain. And it works for emotional pain as well. So people who are really struggling with a history of trauma or abuse and neglect or depression or anxiety, things that are crippling and emotionally, they're in agony. It's really very difficult to manage some of those issues. So there's a natural draw to the opioids for those folks as well. So it's not always when we think about just managing chronic pain or something like that, but I think if we consider that whole realm of people who suffer emotional pain as well, we begin to get a better cross-section of people who may be caught up in this kind of addiction.
Scott?
Well, I guess I can start out by saying that from my involvement with the opiate problem is that I run the largest detox center here in Hancock County. And, you know, I can kind of laugh and giggle and tee-hee about it, but stop and think about that the people that end up in our facility here in Ellsworth, many of them have mental health issues, many of them have an opiate problem, and there's nowhere for them to go. So they commit a crime, they end up in my facility or our facility, and they go through the detox. We try to find places for them. So that is what my involvement in it, and unfortunately law enforcement has become the collection point for all of those. It seems to be that if nobody else can solve the problem or we don't have any resources, let's call the police and put them in jail. And that's where it ends up. And I will tell you from my point of view as sheriff and that I've had for the years that I've been in law enforcement, is that I know that they don't belong in jail. And I know that we have to, number one, eliminate the demand. If there's no demand, they're not going to come and they're not going to sell. We've identified that a lot of the problems have started with people using prescription pills, overusing them, misusing them, and those types of problems. We now know that, and steps have been taken to help lessen that. But we also know that the problem is with the heroin, the fentanyl that's out there, and these drugs are so addictive, so deadly, so dangerous that they have no control over what happens. It takes over their life, that rules their life. And I'll just share very quickly a story. I had a phone call from a friend of mine today who is a nurse, and her son is struggling with an opiate problem. And we've been talking back and forth trying to get him some treatment. And I think at this point he's finally hit that spot that everybody talks about, rock bottom. He's been living outside, so I think most of us know that today was probably a pretty poor day to be living in the woods. He hasn't eaten for 4 days, and we were looking to try to find him. But I think he's finally come to the point that I can't do this anymore, I need help. So we're scurrying to try to find resources, we're scurrying to try to find places that we can help this person, because I really believe that so many times if somebody comes in and asks for help and we don't have something in place to help them, we may never get them back again, and they're going to end up being a statistic. And if you see the statistics, we've lost 286 people so far this year, which has exceeded the total for the entire year of 2015. So we're on an uptick with the opiate overdoses, and those are just ones that law enforcement has been involved in. If someone overdoses and they're picked up by medical personnel, taken to the hospital, we don't get that information because HIPAA laws does not allow us to have those. So those are just actual people that have been lost that law enforcement has dealt with. So we got a lot of work ahead of us.
Jonathan, that might be a place for you to jump in with a critical insight of yours.
Do my best. So I'm an addiction psychiatrist, and I work at Maine Med. And so I I see a lot of these patients, and we provide care no matter a patient's ability to pay for it or afford it. And there's just not enough of us to provide for the current epidemic. You know, opioid dependence is a really hard illness. The longitudinal studies, when they've looked at people who have heroin addiction and they follow them up over a time period, they had one study that identified people first contact around average age about 22. 30 years later, around age 52, half of them were dead. So that's the chronic nature of this illness. It has very high mortality, and we do have effective treatments for it, but it's very hard to, it's complicated, right? It's complicated. There's a genetic component, there's psychosocial factors that contribute to it. It's really a chronic illness, kind of like diabetes or hypertension, but we stigmatize it and don't think it's a moral failing in a lot of ways. So, you know, my job in a lot of ways is trying to be a spokesperson for kind of the stigmatized and the people who really can't speak up for themselves. But at the same time, it's very challenging to deliver care for patients. It's very rewarding as well. It's, you know, people do really poor or they do really well. And I think, you know, I think I want to just say that some people, you know, people who follow the directions are miraculous. It's really quite amazing what can happen. Even though the morbidity, you know, 30 years, half are dead, the people who succeed can get everything back and live wonderful lives. And so there's a lot of hope, too, in there. And that's what keeps, I think, us clinicians going, that it's really rewarding work. And I want to share that with other clinicians. And so a big part of what I do is trying to get our primary care physicians excited about doing this sort of work so that they want to treat it just like they want to treat diabetes and hypertension, because it's the same type of illness. It's just, there's a lot of barriers to get to that point.
Great, thank you. Alyssa?
Sure. Most of the individuals that I see are about this big with a long tail. And what's interesting is they're all great. There's no bad ones in there, and I think that's really important. So when I can see that there's individuals that will drink more alcohol than others, that will acquire the tendency to use drugs more rapidly than others, I can't say that one of them's bad, one of them's not bad. I have to really look at what biological differences exist within those individuals that make it more easy for them to go down this path. And in talking to some of the students in our addiction short course that we run every year here for researchers and clinicians in the field, they say this is something I could use right away. You know, many of us here we're working on biological therapeutics, ways that we can treat and cure disease. But just gaining that insight that there is some underlying biology and underlying individual differences that may explain at least some of the behavioral differences among people is something that can help towards destigmatizing the addictions and can maybe enable people to seek the help they need and potentially forgive themselves and others for suffering from a disease.
Maybe we can move on to the subject of pain that Dan started with, and talk a little bit about society's attitude toward pain and whether or not this notion that we really shouldn't feel physical pain, we really shouldn't feel emotional pain, has led to overprescription of drugs. And how we should think about that going forward. And Jonathan, maybe we can start with you on that one.
Well, you know, we have a current opioid epidemic, but we've had multiple opioid epidemics. They cycle. They come, you know, remember we used to have patent medicines? You know, like if you take a look at the cowboy movies, right, there's people using laudanum and kind of addicted to those things. So we've had multiple epidemics of opioids. You know, when Vietnam veterans started coming back from Southeast Asia, we had another opioid epidemic. It's repeating. It always repeats, and because the underlying things that lead to it are from are differing ways. This current epidemic has been probably fueled by overprescribing, and so we've shifted through time, and there's a pendulum, and I like the analogy, moral Calvinism. So like, we are, you're strong stoic individuals, and you should just be able to deal with the pain and kind of just be okay, to this kind of idea of pharmacologic hedonism, like a pill for every ill. Like, we don't have to, now we have the technology and the ability that we can kind of like just be able to kind of, have a pill that will take care of everything and everything is going to be okay. And so we swing back and forth. And this one has really been fueled by kind of this, kind of going in that direction, probably promoted initially with good intentions. We were very restrictive on opioid pain medications. When I was a kid, you broke your arm and it was actually hard to get a Tylenol number 3 for a broken arm. And that changed. Some pain researchers recognized that like people were being undertreated, and they showed good evidence with controlled populations that you could use powerful opioids and it was safe and people didn't get addicted doing this. And then we took that and ran with it, right? The pharmaceutical companies really kind of pushed that to a point where we introduced the 5th vital sign of pain. And so JCAHO did that. JCAHO is like the accrediting body for hospitals and most mental health and medical settings. And so once you introduce that, and you use that as a quality metric, right? So how was your care? Was your pain adequately treated, right? And so now you're using this to kind of measure performance at a medical level. So we went the other way. We went all the way to giving OxyContin and oxycodone to people for smaller surgeries. And I'm sure, you can tell, you have a tale of like you went for something and you have 60 oxycodone in your medicine cabinet. And so one thing we do know about addiction and substance use is with greater availability, there is more use, right? Maybe the person who has it didn't use it, but maybe someone else takes it from their medicine cabinet or diverts it or something. And so it's not a surprise that it went that direction. And like the commenter before mentioned, opioids have been around for a long time. Before we had antidepressants, we used opioids to treat depression. We've used them to treat psychosis. Like we used them to treat everything because we didn't have any medicines. And so they're very effective not only for physical pain, but mental pain. And so in areas, some of the I can go on, so please stop me if I, but in some area, like Maine is a very rural state, right? And in some areas, there's not that many practitioners. And there's a lot of areas with not much opportunity for the population. And it's a whole lot easier to kind of give a prescription that will make people feel good, and you can write it really quick, than not. And that was the push that kind of went in that direction. And we're seeing the consequences of that in some way. If it wasn't opioids, it would have been something else, right? And I think that's the point to take. Just because it's opioids now, the genetics of it, the percentage of people who develop addictions, it's kind of constant. Goes across all socioeconomic classes. The genetic vulnerability is there. And it doesn't matter if it's opioids or something else, people develop addictions. There's some, differences between exactly what it is entirely, but if the availability is higher for that, you have to have the exposure too. Just because you have a genetic vulnerability, if you never tried it, right, then you can't possibly get addicted to it, right? So there's a lot of things at play, but the pain and this idea that, we don't need to feel pain at all, it's where we kind of go with it. And, pain does have a useful purpose. We have evolved, right, to feel pain because it sends a signal that we're not supposed to ignore, right? If you have something that is painful, you have to go and take a look at it and get it checked out and kind of fix it, right? Like, and not use that area so it can heal and like do all these things, right? There is a purpose.
So I'm going to move to emotional pain here, but I was born in 1950, and when I was 8 years old, I acquired what is still an 1.5 inch scar on my thumb. Went to my pediatrician, whose name was Russell Morissette, and you know, he cleaned it, and then he's getting ready to stitch it up, and he's got the needle there, looking big and ready to go. And I said to him, "Gee, you know, don't you give something to people to keep that from hurting so much when you do that?" And he said, "No." He said, "We don't." He said, "We figure you'll be remember to be more careful next time." It's a true story. So I think these things do go in cycle. One of our guests here tonight is Susan Santangelo from Maine Medical Center Research Institute, and we were chatting a little bit earlier. Alyssa, this one's coming your way, and talking about pain. She was saying that in some studies she's seen with mice, that if the mice are happy and living in a community, have plenty to do, even mice who might be more genetically inclined to push the button and take the pill don't necessarily do it. And I wondered if you've seen that in your research and could comment on it.
Well, we haven't looked at that exact phenomenon explicitly, but it's true that housing, stress, all these other factors influence the extent to which individuals are going to pursue drugs and feel pain, even if they're surrounded by other individuals. They're seeing other mice that are experiencing distress. They themselves perceive distress and might be more sensitive to pain. So they're actually investigating social networks around pain sensitivity, much like they look at social networks around obesity and other things. So it's true that the opportunities that one has available to them can influence the range of activities that one gets involved in, right? And one of the devastating things about the addictions is that it really restricts the range of activities that someone engages in to where their behavior becomes almost exclusively centered around procuring and using and withdrawing from drugs.
Scott, you want to comment on that?
Well, I see the people that come into our facility, and I see the people that I deal with on the street, or our people deal with on the street. And as you say, there always seems to be something underlying there that causes them to do that. Because, you know, everybody deals with stress, everybody deals with pain in different ways. So it's difficult when we get them. We're just not trained to deal with that. We're not trained to determine what their problems are and all this stuff. So again, that goes back to what I say. So many of the people that we have incarcerated, not only in Hancock County Jail, but in jails all over the country, need counseling. They need services to help identify what is the root, what's causing them to use these substances, and what's causing them the pain and the discomfort. And you know, I'm a firm believer that you can't solve a problem until you identify what the problem is. And these people that are in jail that are addicted to this may not realize what the problem is, or may not be able to identify that is. And if you don't have counseling services and medical professionals that can deal with that, man, I'm a police officer. You know, that's way above my pay grade, and that's way above what I'm trained to do. So, you know, I'm looking for every possible way that I can to get services into my facility, to get these people the services they need, identify that problem, and then once we've identified what the issue is to treat them properly, the way they should be treated, and treat them like people. You know, I think most of us, my generation growing up, if you asked them what a heroin junkie was, well, this is some homeless person living on the street in the city of Boston or in New York, you know, sticking a needle in their arm, living in a refrigerator box. That's not true with what's going on here in Maine. I mean, these are people that live next door to you, and these are people that many of them do, until they get to a certain point, hold jobs and support families. But when the addiction continues to get greater and greater and greater, they don't have that ability, and then you see them quickly go down. And again, law enforcement is the bottom down there. We're the ones with the catcher's mitt. We catch them, and they deliver them to us, and they say, good luck, figure out what you're going to do with them.
Dan, I want to turn in a minute to how people can get help. But before we go there, you were really the one who started talking about emotional pain as well as physical pain, and building on the comments that the others have made. Are there things that we could be doing as employers, as a county, as a community, to help fill some of the void that people feel, and in a way create that better housing situation that Alyssa's mice perhaps enjoy?
Well, I think there are those variables that are really important, that we have Maslow's hierarchy of needs. We need to make sure we have the safety and food and housing and things like that, and then we build upon that. But there's a lot of people that aren't secure financially or have health issues and whatnot. In our center, when we work with people with addiction issues, we don't just focus on addiction. We focus on their entire life. When we talk about recovery, we're talking about their recovery from their addiction, but also their physical health, their housing, their finances. I have quite a few lobstermen that come to our center, and I have one gentleman I've worked with for about a year and a half now, who came in. He had significant heroin addiction. He owed money to everyone in town. He was living with his parents. He had a child that wasn't in his custody, and at 1 year we reviewed his where he was, and we did a retrospective. And he had a bank account, he had a home, he had his child and his partner living together, and he was just beaming. And like they do recover. The success stories can be very dramatic, but there isn't that safety net. And I think that's what Sheriff Kane is talking about too. That people who slip through that safety net. So, as employers, these are issues around insurance. These are wages that allow someone to be able to sort of have enough food and adequate clothing, and so. Some of the needs are so basic. We just deal with those. But we have, I worked 21 years in a psychiatric hospital, so I'm really familiar with JACO, and I'm familiar with, getting dinged for not having the adequate pain treatment. But when I was 27 years old, I was in a head-on accident with a drunk driver. Actually, he had alcohol, cocaine, and marijuana in his system. And I was on a motorcycle. So I spent 3 months hanging in traction in a hospital in Carmel, California, reflecting upon my life. So I ended up with chronic pain, and so I do groups with people with chronic pain, and we talk about how do we manage that. And there really is there are options besides opioids. Opioids actually are not a solution for chronic pain. In fact, a relatively high percentage of people can come down with what's called opioid-induced hyperalgesia, which is a greater sensitivity to pain from using the opioids. So the only one who benefits there are the pharmaceutical companies, right? It's addictive and it can raise your pain threshold. So I work with people doing cognitive therapy, doing meditation, doing behavioral pacing. And we have two main goals in the groups I lead. One is to decrease their perception of pain, and second, increase their functional abilities. And people with chronic pain are okay with that. They're not really looking for, my pain's going to be gone forever. Most people realize that's not realistic. But if I can just have a little less pain and I can do a little bit more, then that would be a good outcome. So I think we have to get into a range of expectations that are realistic. But if you are an employer and you see someone in your company and they're exhibiting behaviors that either it looks like they're suffering from chronic pain, that should be addressed. Or if they're starting to become more isolate and not engaging as they normally would, someone should check in with them. I mean, we can sort of help each other as we in a workplace. I mean, a good workplace is one where people notice these things, and we show we care for people. So It's that kind of thing I think is important.
So this will be more for you and Scott, but I'm also going to ask Jonathan to weigh in from an outside of Hancock County perspective. If I have a problem, if my loved one or a friend has a problem, where do they turn for help? What can they do?
Well, the good news is that there are really good treatments for opioid addiction. It is, unlike some addictions, abstinence is not a viable option. The recidivism rate from programs with abstinence is very high. It's not to say it's not a good goal, and we often we'll get there. But there are two primary medications that we use. One is methadone, and I worked for 3 years in a methadone program at this hospital. And the other is buprenorphine, which is prescribed by physicians in an outpatient setting. It's the primary ingredient in suboxone or Subutex. So those are called medication-assisted treatments. And what those do, they hit the same receptors, but they're very, very long-acting. The drugs of choice are very short-acting. They have a short half-life. You get a quick high, and then it comes right out pretty quickly, and you're into withdrawal fairly soon. These other medications have very long half-lives, between 24 hours and 36 hours. So, there isn't a high. There is just a fairly steady state. So what that does, immediately the person stops craving the medication. It stops withdrawal. It stabilizes them. They no longer have to wake up in the morning and say, how am I going to get my fix? How am I going to meet this? I've got diarrhea. I'm nauseous. I just feel horrible. When I was in the hospital in California all those years ago, I took myself off my pain medication one night. I was an angry 27-year-old that wasn't feeling any pain. On a Friday night, I took myself off it, and I threw a urinal at a nurse, and she decided to leave me alone. And then it fell off, and the weekend, some local tenants came in, and docs that were just covering, and it fell off. So I went through withdrawal that weekend. So I know what that feels like. It's really horrible. I can't say that I gave the hospital a high grade for diagnosing that, because no one did until my other docs came back on Monday morning and said, who took him off? And they said, I guess he did. And they said, he doesn't know what he's doing, which was true. But there really are options, and people who are on buprenorphine or methadone can stabilize, but that's only one part of treatment. And I can't emphasize it enough. Once they're stable, the counseling, the therapy comes in to resolve those issues. And getting back to what Sheriff Kane said, we've got to get to the underlying reasons why they were susceptible. Now, we know there's genetic predisposition, but there's also environmental factors. And regardless of that, if you've had addiction to opioids, you've probably developed a problem with the law, with family, with employers, with school. It really impairs your life. So we've got to put your life back together. But when they're stable like that, it's amazing the progress that someone can make. So the message I keep saying is that treatment works. Now we don't have enough treatment options in our area, and Arpane and I are on a group with Dr. Kufler, who's here. We meet and we're developing a model for a county-wide suboxone program to help meet this need. In my program, we started a suboxone program about 1.5 years ago, and we just capacity was met almost instantly. And I can hire more people, but the need is so much greater than what we can provide. So we have to sort of come up with other solutions, but there really are good options for this, and people do recover.
I appreciate the fact that there are options, but whose door do I knock on? Do I go to Art's emergency department? Do I come to Acadia Family? Do I go to the sheriff and beg him to help find me help? What do I do if I have a problem?
You do any of those things. You call the Acadia Family Center. You call Open Door Recovery. You call Community Health and Counseling Services. go to the emergency department at the hospital. They know what the resources are. The problem is capacity. You know, if we need more capacity. One of the issues we deal with is that buprenorphine can be prescribed by a family physician. And we have some family physicians like Dr. Kufler and a few others who are willing to do that, but not every physician feels qualified to treat addictions. So there's a hesitancy there. There's maybe a worry about, well, I've got a very busy practice now, and how could I take on more? So there's a reluctance to sort of, they need to get a waiver, which is like an 8-hour online course. They get to sort of review the necessities of how to do that. So we're trying to help encourage physicians to sort of take that step. And the model we're looking at is if we have a hub that sort of stabilizes the person for a couple of months, then we have spokes to the different communities where the community providers can then pick up the prescription and the local counseling agency can provide the counseling. So that's the model that we came up with. But we need those community providers in the spokes in those communities to be willing to do the prescribing. And that's something that we're making progress with it. And we want physicians to feel supported. And the model we have, if there's any issues with those in the spokes, the person can come back to the hub and we'll sort of help restabilize. So we're doing whatever we can to sort of encourage them to do that, because that would allow us to really treat a lot more people.
Scott, I'll come back to you in a second, but Jonathan, I know you're thinking about and worrying about some of these same things. Do you want to comment on what you're doing and how people in other parts of the state are getting help?
Sure. So 211 is a great resource all across Maine to look up what community resources there are wherever you are. You can search by county. It's a Maine state-run compilation of all the services for mental health, addiction, housing, all the things that we're kind of talking about. So there's a web page and you can call. And so you can search Hancock County and kind of see what is out there, including sober houses, methadone programs, addiction treatment programs. So I would refer you to that resource because they've already done the work of compiling it, kind of. That said, there is a capacity issue, so how do you get in the door even though that thing is there? There's wait lists. And no one really likes publishing the wait list of like how long it is to get into those places. So if you have no resources, it's going to be a longer wait list than if you're able to pay for it. And that's just the way it is right now. We don't have enough financial support for all of this at this point. That said, Maine Health is kind of taking a very similar approach. We're doing a kind of a hub and spoke. So this hub and spoke is a very kind of, Vermont does that. So, and so that's, but we don't want to say we're Vermont. But it's a good model, especially for a state like Maine where we're very rural and we have, you know, our most acute services are really kind of concentrated in the bigger metropolitan areas. And so how do you get to someone who is way out in Lubec, right? Like how do they get into treatment? Like they're not going to be able to drive to like a methadone clinic or Fort Kent. How does that happen, right? And so a hub and spoke model is a good paradigm for delivering care across a large geographic footprint. And so Maine Health is trying to do the same thing. Basically, at the hubs, you can provide the most acute level care, and you have the expertise to support the spokes where you have smaller practices. It does, you know, if you have the worst sorts of addiction, you kind of need the biggest services, so you do have to travel to get those services. But it also means that, like, we can't just treat people in hubs, right? We can't just treat people in like the hospitals. That's not the way to kind of do it. It's kind of like what I was saying, like we want our primary care docs to take care of it, like, you know, like diabetes, like anything else. And so where the capacity in the system really comes with this model is in the primary care centers, because that's where you can build the capacity. But it's for the more stabilized patients. And so it's all good to kind of do that, but you can't just take the acute cases and put them into the primary care practices, because you're going to turn the primary care docs off of trying to do this work because it's going to be a disaster, right? So you kind of have to do both at the same time, and it's challenging, and that's kind of my role at Maine Health, is to try to encourage our primary care docs to do this, working side by side, provide support for them, lower the burdens by providing a lot of the providing. So, you know, like taking care of these patients, there's some additional administrative burden because we are waivered, we have to track the patients, and the DEA can do site visits and wants to see how many people you're following and all this stuff, and then you do urine drug screens, which most primary care docs don't do, right? And so how do you do that? And then we provide behavioral health too, and so we have a robust system of integrated behavioral health in Maine Health, where at our primary care practices, we have integrated behavioral health people. And so we have a good groundwork already done to kind of implement this model. And so we're fortunate in that way. But I think the approach it's a great approach. And I don't know, I think everybody is kind of doing that same approach because it makes the most sense, really. But it's challenging. It's a learning curve and changing attitudes, and primary care docs, I'm sorry, you guys are overwhelmed already, right? And now we're asking you to do more. It's a hard sell. It really is a hard sell.
Scott, do you want to comment on getting help in Hancock County?
Getting help in Hancock County, yeah. I guess I'll back up a little bit and describe our situation. We are, I guess for lack of a better way, we're the Dunkin' Donuts or the McDonald's of detox, because they drive to my door, they drop them off, and they drive away. And so here we are. We have these people. We do not allow inside our facility drugs that would help with detoxification. We just don't let them in there. There's too much of an opportunity for those to be shared with someone else in there. So as cold and cruel as that may sound, we do not, and no facility in the state of Maine does that. So we've immediately got a person with a problem. And this may sound like a snide comment, but I dial 1-800-Barbara Royal, and she doesn't happen to be here today. And for those of you that know Barbara or have ever met her, she's an absolute miracle worker, and she's a saint. What she does, I call it, she must get sick of me, and I suspect that many members of the community calling her. She never says no, and she does everything in her power. She cares about everybody that has an addiction problem, whether it's opiate or whatever it is. So that's where I start. The other thing in law enforcement is that you see there was a project started maybe a year and a half ago in Gloucester, Massachusetts, the Angel Project, where if you are an addicted person, you have a drug problem, if you come to the law enforcement, turn in your drugs or just come and say, I've got a problem, I need help. They have a system in place in Massachusetts where they can immediately get them into treatment. They get counseling if they're incarcerated and those type of things. So they have that. The key difference between Massachusetts and us starting a program similar to that in Maine is that healthcare covers that in Massachusetts, and it doesn't cover it here in the state of Maine.
Exactly, yeah.
So these people, I'm sorry, I apologize, that's a generalization. The people that have the problem, the majority of them don't have health care, and it's not there available. So to pay for it is unbelievable. We're working with the Ellsworth Police Department and actually with the other departments here in Hancock County, which has started Project Hope, which is a spin-off of what they've done in Gloucester, Mass. We have been given some contributions with some dollars, very, very few dollars, but we're stretching them as far as we possibly can. The young man that I talked to you about a little while ago, his mom is going to try to get him, and I've got an appointment set up for him first thing Tuesday morning, if in fact he's decided that finally he has landed at the bottom and that he's going to go and do something with this. So we stretch what few dollars that we have. This is a learning process for us. As I said, I'm a law enforcement officer. I don't have a medical degree. But I see these people, and as I said before, it's not the stereotypical person that you would think that has a problem with opiates. It's the person that was a fisherman and got hurt on his boat and started taking pills, and all of a sudden it got the best of him and took over him, or it's somebody that drives a backhoe, or it's somebody a housewife that slipped on the floor doing something and was prescribed pills. So they're all different parts of our society. And as I say, I suspect probably everybody in here knows somebody. And I see people nodding all, yeah, everybody knows somebody that has this problem, and it's overwhelming. And again, I'm not crying because so much of that ends up in I cry about it because I don't have any resources to go, anything to do with them. I just was given some information about a drug, and maybe some of the people, Vivitrol. Mm-hmm. And Vivitrol is supposed to be a blocker, as I understand, for opiates, which would be in a long-lasting, my understanding from what very little I've read about it, is that it's a once-a-month injection. It lasts for 30 days, and that it reduces your craving. That your craving is not reduces, it's gone. So the craving and the problem that you have with the addiction disappears with this drug, and they're working to try to see if that's something we can use in jails to begin with, and so forth and so on. So maybe there's something out there with that can be done with that. So there's no services. I asked Barbara, I said, if there's one thing that if you had a magic wand that you could put here in Hancock County that would get us started in the right direction, she said, it's detox beds. We need beds to detox beds. But the other piece that we haven't gotten that far with, too, we take this person and we miraculously turn them around. And what do we do with them? We kick them back out in the community. They go back to the same people that they hang out with. They go back with the same environment that they will work with, surrounding themselves with the same friends that they had, who most likely are addicted the same way they were. The temptation, the greatness to relapse and fall back in is just incredible. So the aftercare piece, after we finally catch someone and help them and get them pointed in the right direction, there needs to be aftercare. There needs to be resources where this person who hasn't been employed, where we can find them a job, where they can put a roof over their head, where they can support their family, maybe get their kids back or whatever it is. So it isn't just identifying and treating. There's so much of that stuff on the other end of that aftercare stuff that we really need to look at too. We need to have long-range plans for these people that we're able to catch and help.
It's a really important point. For a chronic illness, you could look at cancer, another relapsing type remitting illness, and you wouldn't give people a graduation ceremony when they finish cancer treatment and then send them on their way. There's extensive follow-up every year to ensure that there's no recurrence. And that's not what's done in addiction treatment. It was really interesting. I got a letter earlier this week from someone in Maine State Prison asking about Vivitrol. It's not available. So we know there are things that work, that there aren't resources to provide.
One of the issues with detox, though, is that if someone goes to jail, for example, they're detoxed, right? And they spend 6 months or a year in jail. When they get out of jail, they'll very often go back and start using again. There hasn't been any treatment, right? So because they're no longer physiologically dependent, they're still psychologically dependent. In fact, they've been thinking about this drug for 6 months in jail, and the problem is they come out and start using or try to use at the same level they did when they went in. Well, we know that they had developed a great deal of tolerance before they went in, and they have lost that tolerance being without the substance, so they'll come in and they'll overdose. And these are some of the people we're talking about. When I worked at the narcotics treatment program at the Acadia Hospital, Glenn Ross was the sheriff in Penobscot County. We brought methadone to the inmates at that jail. And we had our nurses go over and dispensed it, and those people stayed in treatment. And when they get out, they could come right back into our program if they're in our program. So if we could develop a model that we could offer them treatment in the jail so they're not losing treatment, or at least they're starting to build a recovery. So when they come out, they're not craving and whatnot. They've been stabilized, and they could then go ahead and finish the work. We'd be ahead of the game. But it does come down to resources. We don't have the same resources. We spend billions and billions of dollars on addiction. 700 billion is one of the figures I heard recently, but a very small percentage of that goes into treatment. And we're not being effective we're what is it? Penny wise and pound foolish. You know, we really could get a lot more efficacy from those dollars if we put it into treatment rather than into corrections. And like you said, we can't arrest our way out of this problem. No. There was a quote that you gave, and I thought it was brilliant because it captures it perfectly. That's not the solution. So,
I've been looking through the audience's questions, and we've actually done a pretty good job of covering a lot of territory. But maybe, Dan, either you or Jonathan could talk a little bit about why people have to stay on methadone so long, or suboxone so long. Jonathan, you want to take a crack at that?
Sure. So I usually try to separate addiction into like two different parts. Like there's the biological part of it, right? Like there's, you know, if you stop taking it, you're going to get withdrawal, and that's not good. And while you're taking it, you get, you know, you keep on wanting more and more and more. So the medication, the methadone, the suboxone, is very good at handling the biological part of it. It has nothing really going on for the ritualistic or the behavioral part of it, right? We get rituals. It's kind of like with cigarettes, right? Like nicotine replacement is pretty good for the biological part of cigarette addiction, right? But it doesn't do anything about the ritual of like packing your cigarettes and then smoking the cigarette and rewarding yourself with a cigarette and hanging out with the people who smoke the cigarette. And it's the same exact thing. So there's like two parts, and the medication does one part, but it doesn't really do anything on the other part. So that's one part of what we're talking about. So how do you address that other part? Well, traditionally, it's through the psychotherapy, the therapeutic intervention, that we kind of teach better coping skills for addressing those parts, try to extinguish the people, places, and things, right? Try to identify emotions that start coming up, try to address the comorbid conditions that often come with it, like mental health problems, the medical sequelae, and so you can try to advance on those things. So it takes a little while to do that sort of thing. It doesn't happen as quickly as, you know, like overnight. In fact, we don't even say someone is in early remission from a substance use until it's been 3 months since their last use. That's a long time. That's kind of radical, right? Like, oh, like they just stopped using, so now they're cured, right? No, 3 months, it's early remission. It takes a full year for it to be sustained remission, and the best data suggests that at 5 years, then you're pretty confident that they're going to be able to stay. So that's a long time frame, and we don't like usually thinking of time frames that long. So that's part of it, right? The other part is those psychosocial determinants that we kind of already talked about. So by the time they're seeing me, their life isn't going very well, right? It's interesting. Usually the job is the last thing they lose. Why do you think that is? Well, they got to pay for it, right? So interesting, like family, friends, stuff like that. That's much earlier than losing the job. And usually they're able to keep the job for a while, but once they lose the job, then things really start going downhill. And so I want to see them put their life together in a place where they're able to have a support system that's going to be able to sustain their recovery. And so they're not at that place when they come. And so I want to see an intact family, get their family back together, like that great example. Be able to have a support network, a recovery network, people they can reach out to. They're often very isolated, right? Have healthy people in their lives. Have a job, go to school, get those things going on. Have their medical conditions adequately taken care of. Have their mental health stuff adequately taken care of. And then you're at a point where you can eventually come off those things. The data for methadone is pretty bad about coming off of it. The one study that I usually quote is by a year of people who were on methadone maintenance, people who came off of it, 82% had returned to IV drug use at a year. So that's pretty damning, really, for methadone. And we just haven't had as much experience with suboxone to know what it is. But I tell my patients, you know, if you have that serious addiction that you've kind of come to the point where you've lost everything and you're using IV, I want a commitment that you're going to stay in the program for at least a year, and more realistically 5 years for us to come off, because it takes a long time to build that support that you need. You know, people think that they're riding on the white horse and, you know, everything is good. Not everybody is ready to kind of welcome you at that point. You know, our credit score, how long does it take to like recover from a bankruptcy or that? You know, like 7, 10 years, right? And the trust of people around you in your life takes just as much time. Regular payments over the long term will eventually raise your credit score to sufficient amount that people will trust you and you're at a better point in your life. And that's, no one likes to hear that, right? Everybody, we want to be better right away, a quick fix to our problems. But success, that's what I look for. So about the 5-year mark, if they are able to put those things back together, then I think it's safe to go through the biological withdrawal, that they don't need that to support it. Try going through opioid withdrawal when you don't have that stuff in place. Like, it's a recipe for disaster, right? But that's the ideal, in my view. There are realities, and then some people don't have an addiction to the point of that where everything has snowballed to that level, and so that's not really necessary, you know, for everybody. So prescription opioid dependence is someone who's been on high opioids but hasn't really crossed, you know, it's pretty taboo to go IV, right? Like, hasn't passed that line, you know, or, you know, hasn't gotten to some of those consequences, then they may not even need to stay on opioid, you know, buprenorphine for like even a year, right? So it really depends on the severity of the illness. And for heroin, IV heroin, the patients who end up going to methadone, they are the patients with the biggest addiction, because methadone is more effective than suboxone. It just is. Methadone, you have to go every day, and yet it retains people in treatment better than suboxone. So it's pretty onerous to have to go to a clinic every single day, and yet it retains people better in treatment than suboxone does. So that's pretty profound of what it can do. Like, it's very potent, it really does work. But the people who end up having to use that gold standard of treatment have the addiction to such a high point that they need that much. And so it's kind of, it may be, you know, saying like you'll never come off methadone, we're maybe not talking about the same things, right? It may just be an enriched population for the highest levels of addiction.
So I think we've done a pretty good job covering the subject. I think we've covered many, if not most, of the audience questions that have been asked. But let me ask, is there anyone in the audience who would like to ask a question before we close tonight? You first, and then we'll go up there.
I don't really have a question, but you talked about the demand, and nothing infuriates me more when I read the newspaper. I'm a nurse locally, and I read the newspaper, and it's all the physician's fault that we have this opioid problem. Nobody else's fault, just the physicians. And I wonder why first, the pharmaceutical companies have no accountability to this problem, but they're pumping it out like candy, more than candy probably. And then also, why is it that these patients are usually on main care, and why our state level, you know, there's no resources, there's no insurance level. And so I see that, like, on a state level, the politicians or Augusta takes no accountability either. And so, you know, these people are getting dumped at the jail or our ER, and yet everybody else is immune to the problem. It's maddening to me that you pick up a newspaper and it's all about the physician prescribing an opioid. So I just wanted to make that statement because I felt like it was really missing about the demand piece.
Thank you.
Sheriff King, do you use naloxone?
I'm just finishing the policy and in the process of getting my deputies trained to use that. And also, in order to do that, I've got to make sure that every one of them are CPR trained. So I'm in the process of going through all my offices so that they can do that. So I'd like to think by the end of the year I'm going to be able to do that. I do have a policy. I just need to have it approved by our insurance carrier that it makes sure that we administer it properly and that my guys, my people are trained properly to do that. So I do not have it in place now, but I'm in hopes to having it by the end of the year, or at the worst, the first part of the year. And again, that goes back to, and again, I'm not looking for pity, but it goes back to law enforcement people doing things that, I've done this for a long time, and when I started, I want to be a police officer. Well, now, so now, I'm a police officer, I'm a guidance counselor, I'm a child health care worker, and now I'm a medical person. At some point, somebody else is going to have to take some of this load, but I'm a firm believer in my deputies carrying that. It's just a matter of getting everything in place. It's critical enough to me that we make sure we do it right, so that when we do, that we can hopefully save somebody, if God forbid we need to.
I'll explain to the audience, it's the reversing agents, so if there's an overdose, it reverses, so it saves lives. And there are many, I have families call me fairly differently, they want it in their family to be able to use it.
I've seen it work once, and I will tell you, I'm a believer. I saw that administered to a person in an emergency room, and that person sat up as quickly as you turn a light switch on. If someone had told me that's how quickly it works, I'd just, no. That stuff is unbelievable, and right now it's invaluable because many times we're there long before, law enforcement's there long before medical people can arrive.
Thank you. Yep.
I have a question more about when you talk about an addiction gene, that it's biological. Is it one gene, like for instance for alcoholics, is it the same gene as it is for drug users, as it would be for anorexics? I mean, we talk about addiction of so many things, or is it a variation of the same, like one gene, but it manifests itself different ways?
So
I'm
I should have
not
done
a
this. I
scientist.
should have done this for the other questions because we have some people listening at remote sites who may not hear your question. So briefly, the question that's being asked, and I'm going to ask Alyssa to take a crack at it. Is there one addiction gene, or are there a family of addiction genes? And if there is one gene, is it the same gene for opioids and alcohol and chocolate as it is for other ones?
So there's many genes and many different aspects to addiction. So each of the many genes may be playing a role in many of these different aspects. So all of the addictions have some things in common. So there may be some genes that lead people to susceptibility to addiction, and what substance they become addicted to might be influenced by what's available in their neighborhood, whether or not they had a surgery, what were they exposed to. That might influence what substance they end up picking up. But any substance, there are individuals who are just simply addiction prone. Then there are others who either have an abnormal metabolic response to a drug, so you'll see that. There's others that may like a drug may more readily develop a craving. Vivek Kumar, who's here, found a gene in mice that influence how readily mice enjoy the early effects of a drug. And I use the word enjoy very loosely here, but the early experience of the drug, how strong is that? How impactful is that? So some genes that we're looking at influence the extent of withdrawal. If the withdrawal is say lighter, easier to handle, maybe that person doesn't have an incentive to use right away. So there's many different facets of both, and there's genes involved in initiating substance use. Some individuals are out there trying many different things. This is a good quality. It's great to look for new things. It's good to be an entrepreneur, seek new opportunities, but it's maybe not a good thing to try every drug in sight. And so those genes that lead to that kind of more impulsive behavior could also influence how readily someone becomes addicted to drugs. So many different processes, many different genes involved in each of those processes, some overlapping across different drugs and some very specific to drugs. It's a very complicated problem.
Right here.
I'd like to
see if you could broaden this a little bit to dealing with food. And since obesity is such a problem in our world now, and obesity in children, I'd like you to comment, if anybody can, on the roots of food addiction to a variety of trigger foods that set up a craving in some, but not in others, similar to alcohol. And I'm not sure how to comment on that in terms of drugs, but I certainly have seen it a lot with food.
So for those who are listening in our remote locations, the question is, could the panel speak about obesity and some of the factors that cause people to crave foods of various kinds? Anybody want to take a bite at that?
Well, it is. There are many types of addictions. We're talking about the brain reward system, right? So there's certain people who prefer certain foods, and if that lights up their reward system, there's extra craving and so forth. But absolutely, there's when you look at some of these, it's a brain hijacking of some type, whether it's going to be gambling or substances or pornography. It's the same circuit that requires that one side, the nucleus accumbens, becomes somewhat numbed, and that we need more and more and more to sort of stimulate it. The ventral tegmental area gets more sensitized, so it takes less and less of cue to sort of make you want to do that behavior. So, and then the prefrontal cortex, which is involved in this whole system, which we never really got to, which is really interesting, that controls insight, judgment, planning, but also willpower. So people who suffer from addictions, and this is the same for food, I would say, is that I can push away the donut. Why can't you? Well, if your prefrontal cortex has been damaged from continuous use of a substance, you don't have the same amount of willpower, which is why we call it a chronic disease, which is why we don't get into moralizing that they're a bad person or they're weak-willed or whatever people have said in the past. We want to sort of move beyond that. And so the more and more we understand that, that's why the Jackson Laboratory is doing some fantastic work and really promoting the science behind what's causing these issues. So we're getting better at understanding it, but that's how I would take a shot at that. I think it's the same circuit that's involved.
Vivek, you work on neural pathways in the brain and how they're affected by different substances. Do you want to comment?
Absolutely. So all these diseases, whether it's
Can you speak a little louder?
yeah, all these phenotypes or diseases, whether it's food binging, obesity, or whether it's hard drug use, it's acting on the reward circuitry. Now, that circuitry didn't evolve to respond to cocaine or heroin. It evolved to respond to natural rewards. Natural rewards are food, sex, exploratory drive. An animal, if you imagine us many, many millions of years ago, always has to make a decision every day in the morning. Am I going to stay safe in my nest, or am I going to go out there and explore, find a new mate, find new source of food, find a new place to live? And it's that survival circuit. This reward system is regulating that. So yeah, so in fact, like the gene that we found that regulates cocaine acute response, someone else in Boston University just showed that it also has an effect in food binging. And they completely independently found it. So yeah, it's the same circuit, and that was very well stated.
Thank you. Yep.
I have a question I think would be mostly to Dan and maybe Jonathan as well. So Dan, you were talking about how much we need to support providers and helping them to prescribe methadone and like the treatment. But Maine is just entering a new law enforcement with the monitoring of prescription. How do you think that might affect the encouragement sort of among the providers?
Are you, Veronica, are you saying the prescription monitoring program?
Yeah. The monitoring program that's just been passed, and the state of Maine will be enforcing it.
Yeah. Prescription monitoring program has been around for a while, and many of us use it. This is a system where Some people, if they're being restricted in their prescription for a narcotic, will try to go to a different pharmacy, a different physician to get a second or a third prescription. The prescription monitoring program allows us to sort of go online and see what prescriptions these folks are having. So they need to sort of agree to this and understand as part of being in our program that we'll have the access to the prescription monitoring program. It's a tool. It's something that can be very useful. I think people who are in early recovery, and I define early recovery as the person is still, even if they're in treatment, they're still thinking a lot like they were before they're in treatment. And they've learned to sort of be secretive and to sort of manipulate the environment so they get what they need, and they really haven't quite understood that they can sort of drop some of those behaviors. So, so someone may be in a program getting treatment, but still aren't sure they'll stay in a program, and they'll try to sort of get extra prescriptions. So I think it's a good tool to have at our disposal for those people early in recovery. Once they're in a stable recovery, they no longer want to do those things. And so you see the behavior change, and the need isn't really there anymore. But for people in early recovery, it can be very helpful.
So one or two final questions. The person in red.
Maybe for one of the two on the end there. For every person I talk to that might be addicted to a substance, I think for everybody that's in the jail, there's 3 or 4 family members that are at wit's end that might come to me or might come to anybody in this room and say, geez, you know, my son, my babysitter, my husband, whatever. Do you guys have anything you could say to encourage them? I mean, I just tell them to love them, and that, you know, they kind of need, the people that are addicted need to want to help, to get help.
So I can talk a little bit about it. So one of the things that does affect treatment outcome is family involvement. So if the family is involved, it actually improves treatment outcome. So that's nice, right? Like we got something. Length of treatment is also important, right? Employment is important, but family involvement is important too. And it's challenging for family too. I would also recommend Al-Anon because there are ways that you can help and there's ways that you can hurt. And family members also need a lot of support because they can be exhausted. And that's kind of the purpose of Al-Anon, is to really help those, it's to help the person who, you know, is having a problem with an addict, an alcoholic, that terminology. I recommend it a lot for patients and families.
I agree, and I think the idea that if you have someone in your family that you're worried about, there's so you might see Dr. Drew and his online reality interventions or whatever, but that's really dangerous. I don't support that whatsoever. These people need support. They need connection. There's actually a good TED Talk on this. Johann Hari has a TED Talk on addiction. He says the opposite of addiction is not sobriety. The opposite of addiction is connection. And that's where, you know, I work at a place called Acadia Family Center because we believe it's a family disorder. It affects everyone in the family, not just the person using. So you said it, they need compassion, they need support, they need love, they need know they're not going to be abandoned because of that. Now, sometimes behavior is so outrageous, you have to set limits, and you sort of do that, and you have to take care of yourself. But try not to exclude them. Try not to isolate them, because isolation is what drives people to use more, not less.
Final question. Go ahead.
Just to follow up on that, it seems to me what's missing in this conversation, we're talking about the individual's genetics and the individual's treatment and the individual who's incarcerated, and now we sort of thought, well, let's include the family. But one of the larger problems is that we have a community here in Hancock County who reviles people who use drugs, who are angry and frustrated and don't want to have anything to do with them, and it reaches all the way up to the policy level where it's very difficult to pass public policy to support people, to keep them from becoming addicted or using, or even to provide any source of treatment or rehabilitation for them. So what are we doing as a community to treat the community? I mean, who even looks at, you know, how are we teaching the whole community that this is not a moral failure, that this is a disease, that this is genetics? Like, I don't think we'll be able to be successful until we do something at that level.
Well, we're here. Yeah. We're all here.
I was going to say that, and I know Maine Health is working on that. I suspect Art that Mount Desert Island Hospital is working on it. Certainly, the Eastern Maine Healthcare system, which I'm on the board of, is working on it. And probably sad to say, but the more of us who are exposed firsthand to this problem, the more understanding there's going to be, and the more we come together as a community to try to deal with it, because it's very easy to think that someone's bad until that person's in your family and you know them and you love them and you have some understanding of how they slid into this problem. And then all of a sudden, it's how do we come together and help, not how do we chastise, exclude, isolate this person who we think has somehow had a moral failure. And I think if we take nothing away from tonight but this is a disease. It is something that can be treated. It's not something that can be treated easily or casually or without a lot of commitment. And it's something that when we have treatment, that love, compassion, acceptance, connection is going to help reinforce, and isolation is just going to worsen. So speaking of connection, we'd like to invite all of you to join us in the cafeteria, which is to your right out the door. We have food and beverages, and hopefully it'll be a chance for you to ask some more questions of folks who have good answers. So thank you very much for joining us tonight.